when we talk about the social determinants of health, when we talk about the social determinants of health, one is healthcare determinants. We have two components which come out of the healthcare system directly. And another one is social determinants. Yes, and these are those socio-economic factors. Right, and there are strong evidences that spending can improve the healthcare, but not only spending can improve the healthcare. There are several other factors. We talk about the affordability, we talk about the accessibility, and whenever we talk about that, we just talk about that what is government share, what is the proportion of out of pocket expenditure, whether it is coming down or not, what is government budget share towards the health expenditures and all, or the public expenditures as a percentage of total health expenditure, or health expenditure as a percentage of total consumption expenditure. But expenditure is not everything. There are plenty of factors which play an important role in determining the health as a part of the development of an individual, of a household, or of a society overall. So why address social determinants of health? That primarily because we again go back to our universal health coverage topics. Coverage, where we have talked about accessibility, affordability, and quality, and all these things, and at the same time, that to identify the socio-economic root cause of a problem, because the medical sciences have often realized that, or they accepted that the medical, the clinical, the genetic factors are not the only factors which causes health adversities. There are socio-economic factors as well, and that is why we talk about the preventive measures. And when we talk about the preventive measures, we talk about the awareness generation, we talk about the the community specific approaches. Yeah, we talk about the interpersonal communications techniques. Yeah? So and the more we understand about its social construct, about a disease's social construct, economic construct, the we can address the problem at the earliest and before the problem actually arrives. So and the problem can be solved at the short term as well, within a short term as well. So and it is important to change the behavioral aspects, because the behavioral aspects are often associated with the culture, where the culture is associated with the socio-economic background of the person. So once we can track that, then probably it is easier to change the behavior towards a healthier this thing. The major determinants, as we all know, that it can be the income equality. Yeah, we'll come back to that. Education, race, ethnicity, gender, occupation, the housing, the transportation, the access to services, the environment, the social support, so on and so forth. These are the basic major determinants, what we all know. Therefore, whenever we talk about these determinants, we are trying to marry between the socio-economic aspects and the diseases, right? So while we are trying to connect both these socio-economic aspects or the social determinants as well, the health, then there is a theory called eco-social theory of disease distribution. Yeah, which integrates the social and biological reasonings in a dynamic uh, historical and ecological perspective. Dynamic is changing, historical it has a historical root, and ecology again with the environment, with the understanding, with the setup. Yeah, the fundamental question is what is causing the problem, who is suffering the problem, and whether what is population's tendency in terms of causing the problem, in terms of carrying the problem, and treating the problem. And we look at this, both the social as well as the biological constructs of a particular problem. So the historically the construction of this eco-social theory goes back to the 1950s, where there were famines, there were high rate of infectious diseases in several developing countries, just got their independence or still have not got their independence. And then but still many countries are moving towards industrialization, the medical system is developing, the behavior is changing, so the mortality is coming down, that there is a health transition. So the hospitals and then the technology has slowly started entering the society, but mostly among the urban elite. So, and slowly in 1960s and 70s, so it started in 1950s, in 1960s and 70s, it started becoming a right-based approach, that health is a right, yeah. So health education and disease prevention was given importance as compared to technology over here. Not basically the technology, maybe the technical evolutions. Technical evolutions. Yeah, health education and disease prevention and then the poverty and education, housing, water, sanitation, and all these things. Yeah. So during this period, slowly we found that there is a concept of good health at low cost. So certain countries have attained that, which caught the attention of these international bodies. So good health at low cost, that means at that age the certain countries have derived the optimum health condition and the structure systems for that, to attain that. So those countries are China, Costa Rica, Sri Lanka, and Kerala. Cuba is a completely different system, yeah, so we are not really bringing Cuba here. Kerala in India, one particular state. So what they have done, again we know about Kerala, right? The mechanisms are very, very different. China, the government pumped money in different ways, Sri Lanka, it's a lot of awareness generation. Kerala, it's a societal movement, it's basically again a kind of development first ideology, that is the Kerala model. And then in the 1990s, the health and development debate moved towards globalization. Yes, the impacts of globalization in different countries, both in developed countries as well as in developing countries. So, five social and political factors to make good health at low cost could be: number one, historical commitment; two, health as social goal; social welfare orientation; community participation; universal coverage of health services, across all groups, all socioeconomic groups, population groups, and intersectoral linkage, connecting public, private, NGOs, international organizations, for health. And this all can eventually lead to the equity, to attain the equity in terms of accessibility and affordability of quality healthcare services. Now, when we talk about the equity, we are talking about that efficient outcome with, or the best health outcome with limited wastage of resources, right? That is the efficiency, and with to attain that, if the distribution allocative efficiency is attained, the technical efficiency can also be attained, then we can bring in this equity, because then the money allocation will be used at the best way, the capital at the best way. Then there we can ensure the accessibility and affordability as well for those who really need it. And then this equity can be of two types. One is horizontal equity or inequity, two is vertical. It's like equal care to them having same need, no discrimination, right? Everybody has same need, so they will be given the same care, same type of care. And then vertical, the vertical, this is horizontal, right? So treating differently who are relevant in different aspects, that who has different demands or different necessities, treat them differently, right? This is the both equity and vertical. So not only across the groups, also within the groups there can be inequality. So we need to address both of them, across and within. So the 4 key points to reduce inequality can be, the number 1. So if the 4 key points we talk in terms of reducing inequality, it should be reduce inequalities in power, prestige. So I'm not just writing down. So there are basically 4 key points. One is reduce inequalities in power, prestige, income and wealth, because all can attain the health or the better health. Number 2 can be trying to decrease the specific exposure towards a health adversity or the the causes which can lead to health adversity of a particular problem, or can lead to more sufferings of a disadvantaged group. And then lessen the vulnerability of disadvantaged group, that provide better sanitation, better housing facility, better transportation, better working condition. And by intervening through healthcare, and educating them that about the lifestyles, about the conditions which can lead to their health adversities, as well as to prevent which can prevent their further degradation of their health care, as well as because if they know that health care is causing me the poverty, then probably to reduce the healthcare induced poverty. So these are the 4 key points. And then we know, if we look at this social determinants of health or community and social determinants of health framework, then it has also been said that because of the failure of Millennium Development Goals, we had set certain levels of goals to attain in 2015, and in those Millennium Development Goals, they were mainly there were 7 explicit areas, peace, health, protecting the environment and all. So total there were 8 goals, 18 targets and 48 indicators, right? 8 goals, 18 targets, 48 indicators under Millennium Development Goal, which was designed in 2002. So I'll come back to this Millennium Development Goal, 8 goals, 18 targets, 48 indicators. And then they talk about eradicate extreme hunger and poverty, achieve primary education, empower women, reduce child mortality, reduce maternal mortality, HIV/AIDS, environmental sustainability, and partnership among development. These are the basic 8 goals, and it has been stated in 2002, but most of the countries failed to achieve these goals or the targets based on these 48 indicators by 2015. And once they failed to achieve that, then it says that this failure has induced more inequalities across countries or within countries, and especially in terms of development or health. So the equity has been a real challenge for many countries. So when we look at the CSDH framework, the first thing come to our mind, anyways, before again coming back to CSDH, after MDG, that is why they have moved to the sustainable development goal. And in sustainable development goal, what we find is we have total 17 goals, and under those 17 goals we again talk about mostly inclusion and all, and we talk about environmental sustainability, reduce poverty, better empowerment for the women, empowerment for the elderly people, occupation. So all these total 17 goals altogether, so and which look at the sustainability conditions. So basically not predetermined indicators and whether we are achieving that or not, so it is little relaxed, so that is all about sustainable development goals. As comparison to MDG is over, and we have not really done very well in most of the countries across the globe. So when we come back to our CSDH, so we need to have 4 compartments. The first one is the socio-economic and political context. Here comes the government, the macroeconomic policies, the social policies, like say government, macroeconomic policies, social policies, public policies, all these, public policies. So under this we have seen, after this we set up our socio-economic and political context. We have this socio-economic, we need to think of this socio-economic positioning, right? So socio-economic positions, and in these socio-economic positions we have which one? Social class, gender. Class means in terms of occupation mainly, ethnicity, it can be castes, it can be religion, and then we can separately prominently talk about education, occupation, and finally, so this is like this, and finally income, which is easier to understand, and otherwise these socio-economic positions will determine these the policy makings. The policy makings cannot, we learned, right, in that public policy or the public good and all, when we are studying, we learned that the government has to do a situation analysis, then the budget distribution, then monitoring and evaluation, implementation, monitoring, evaluation, and all these things. So and then when they need to do a situation analysis, that is the analysis of the socio-economic positioning, and then this also determine the here it is straight away go to here, the material circumstances, that is the living condition, food, and the behavioral aspects. So we can keep the behavioral aspects separately. Behavioral aspects, And then the last one is psychological factors, or psychosocial factors. Because the social, with the social class, the psychosocial factors will vary. With gender, the psychosocial factors will vary. And then this percolates down to the health systems, how it will be utilized, and finally impact on equity in health and well-being. So again, this leads to this, this leads to this, this leads to this, right? And this is my social determinants of health framework. So we need to understand the socio-economic positions, which deals with the socio-economic and political context and policy makings, and then also at the micro level, the behavior, the material context, the psychosocial aspects, which determine the health systems and utilization, and finally resulting into the health outcomes. Yeah. So thank you very much. In our next class, we will continue with the development aspects. Thank you.